She has multiple awards to her credit, including the best doctors in USA. And I can go on and on to say about this today's speaker, but without taking much of your time, I introduce Professor Roberts to you.
Well, thank you very much. That was a wonderful, kind introduction. I'm honored to be here. Again, this is a topic that's also near and dear to my heart. And I'll just kind of start with a little bit of a background.
Yeah, so all yours, Professor.
Okay, can I advance myself? No? The slides? Well, I'll bring this up here.
Yeah, it's visible.
Okay, sounds great. Good. Well, like I said, this is a topic that's also near and dear to my heart. And it started when I was rounding on babies that were on CPAP, on kind of that 25 to 40% oxygen and really struggling to breathe, but not so much, not struggling so hard that I wanted to intubate them to give them surfactant. So that this was an idea that was born out of that clinical need. So today I'll talk about something that we've coined SALSA, which is surfactant administration through laryngeal or supraglotic airways. And if you've ever heard the saying, you can have your cake and eat it too, or you can't have your cake and eat it too, I'm here to tell you that you can have non-invasive ventilation and surfactant too. And just of note, a laryngeal mask airway, commonly known as an LMA, is actually a trade name by LMA America, a company that makes LMAs. And so the generic term is supraglotic airway, but usually just the commonly referred to as an LMA. For disclosures, I do have a financial relationship with Oni Biotech. They're the makers of InfoSurf. I'm a consultant for their company. And I will also be talking about the LMA, or supraglotic airway devices, which are FDA approved for ventilation, but not for medication administration. And also surfactant is only package insert labeled or FDA approved for endotracheal tube administration. So that will also be discussed, which is off-label. Objectives today, there's several different types of less invasive surfactant administration methods. So we'll briefly go through those. Then we'll look more in depth at the research behind the surfactant administration through an LMA. And then I'll give you a brief overview on how you can do this in your institution and also some resources on how I can help or you can start doing this yourself at your place. So in the past, this is a very common picture of how we used to treat babies with RDS. They have a breathing tube, mechanical ventilation, and surfactant was through the ET tube. However, in this day and age, focuses really on surfactant, or excuse me, on non-invasive ventilation. So this baby's on CPAP. So can you have non-invasive ventilation and surfactant too? And the answer is yes. So briefly going through the 4 different types of less invasive surfactant administration. The first is INSURE, stands for intubation, surfactant, administration, and rapid extubation. The next is via thin catheter, either known as LISA, which is less invasive surfactant administration, or MIST, which is minimally invasive surfactant administration. Briefly touch on aerosolization, and then in the end, focus on the SALSA, or surfactant through an LMA, or supraglotic airway. So first off, INSURE. It's been around the longest. It was initially published in 1990s. It involves a traditional method of placing the breathing tube. The difference is that there's rapid extubation is the goal. So rather than slowly weaning in hours to days off the ventilator, the goal is either immediately or within hours to minutes. The studies that have compared the need for ventilation when giving INSURE versus CPAP alone with no surfactant showed that. Whoop. What just happened here? All right. So the studies looking at INSURE versus CPAP alone have showed either a decreased rate or similar rate of need for intubation or for mechanical ventilation. and that the ability to achieve rapid extubation or need for re-intubation was worse within SURE. This may be due to a lack of response from the surfactant, but it's also most likely secondary to the adverse effects or side effects of the pre-medication that was also given for the pre-medication. Next, moving quickly on to the thin catheter method. LISA, initially described by Dr. Angela Kribbs in Germany, it involves a laryngoscope and a McGill forceps. And the major difference in this versus the Ensure technique is that you're placing a feeding tube through the vocal cords. The baby is completely on like just spontaneous respirations. There's no positive pressure ventilation given at all. The surfactant is administered slowly over 1 to 3 minutes. And again, the baby has a complete control of the respirations, no PPV. This is a still picture of Dr. Kribbs or Katharine Sofferman from the University of Vienna. And she is demonstrating here. This is a picture of a live baby. You can see here the baby is in a bag. They're on their back. She's got the laryngoscope. The McGill forceps is feeding the feeding tube through the vocal cords. And the baby is actually on CPAP. This is an endotracheal tube that's nasally placed. That's in the back of the pharynx, and this is the CPAP hub. So this baby is, again, spontaneously breathing, receiving CPAP. Involves a laryngoscope, a McGill forceps, and feeding the catheter through the vocal cords. The next is minimally invasive surfactant therapy, which was coined by Dr. Peter Dargaville out of Australia. It's also known as the Hobart method because of Hobart as a city. It is very, very similar to the LISA method that involves a laryngoscope. In this case, though, there's a vascular catheter. So it's what you would use for a UA or UV placement, which is a little bit more rigid. So you don't necessarily need a McGill forceps to place it through the vocal cords. Again, surfactant is administered slowly. The baby is spontaneously breathing, and there's no positive pressure ventilation involved. This is a video. Again, you can see that the baby is having a laryngoscope placed. The baby is on CPAP. You need to find the vocal cords. The catheter is being placed through the vocal cords. Laryngoscope comes out. The surfactant is being hooked up and fed. This is the surfactant catheter through the vocal cords. The baby also still has an OG, which is being aspirated at the same time to make sure that the surfactant is going into the lungs. You can see the pulse oximeter here. The baby is doing well. Spontaneously breathing. Next, we'll briefly touch on aerosolization. This is potentially the least invasive and most promising of all techniques. If this could come into clinical practice, this would be absolutely fantastic. The least invasive method. Companies have been searching after this for development for many years now, almost 30. It's been limited by many technical problems, such as attaining a particle size that is small enough, stable, delivered over a reasonable period of time, and given an appropriate dose to reach the airways. The Aero 2 trial has enrolled 457 babies, 23 to 41 weeks with a mean of 33 weeks. It's shown that there was reduced intubation and surfactant by nearly 1/2. This was published in October of 2020. So this is, again, very, very promising. Again, decreased intubations by 50%, but it's not yet FDA approved, so it's not clinically available at this time. This is a video of a baby in the trial. The interface is actually like a binky or a pacifier interface. The baby is again on CPAP and spontaneously breathing, no positive pressure ventilation. The other trial that's currently ongoing is Aerogen, which is the Aerofact trial. And again, they're currently enrolling, and this device setup is a little bit different. But again, babies on CPAP and no positive pressure ventilation. So we anxiously await something being clinically available. And then finally, we'll come to SALSA, which is kind of the focus of this talk. Again, surfactant through an LMA or a supraglotic airway. This was first described in 2004 and 2005, with just some case reports that showed that it could be done. The LMA itself is just placed with the thumb and finger and advanced until you can't advance any further. So there's no need for a laryngoscope. The baby stays spontaneously breathing. You can administer CPAP continuously, and you should, and we'll show you how to do that. And then also the procedure can be done with or without any positive pressure ventilation. So this is a video that shows the procedure. This was a one that was done in my hospital. So you can see the baby is on CPAP. The CPAP itself will, we left it in place just so you don't have to kind of keep fiddling with the baby, but it doesn't need to be. The CPAP itself will actually come through the hub that's attached to the LMA, because the LMA sits in the back of the posterior pharynx, and it's going to cover the trachea. So any positive pressure ventilation that's coming through the nose is going to go right out through the mouth. The LMA itself was just placed by sliding it in. Again, no need for laryngoscope. We have a Y piece on this LMA. Get the video here. The Y piece. And what that's allowed us to do is that one limb has the CO2 detector, which again has been very, very useful in ensuring that we're in the proper place over the trachea. And the other limb then is for the surfactant port. The nice thing about the Y piece is that the CPAP doesn't have to come off when you're giving the surfactant. So there's no interruption in E. And again, this was done with positive pressure ventilation, but it doesn't need to be. So I'll talk through this a little bit more as we go through this, but this again is just demonstrating that the LMA is just placed in the kind of the back of the airway. Again, the CPAP, the colorimeter, the PD cap is showing that there's color change, goes to yellow. The baby is getting some positive pressure breaths, and the surfactant is being administered in 2 ml aliquots. After the last aliquot, initially and during my trial, we bagged for a full 30 seconds. Since then, we know that positive pressure ventilation is more negative, has negative effects on the baby. So since then, I just bag until the baby the saturations have come back up and that feels like the surfactant has cleared. So of these 4 methods, which one is best? I'll go through kind of a quick little laundry list. As you can see here, it needs to, whatever method you choose needs to work for treating RDS. There's the question of what to do for pre-medication, the physiologic effects of the procedure, what patients are eligible, the effect on the functional residual capacity, the need for PPV, potential adverse effects, and also provider skill and familiarity with the device. So does it work? All methods have been shown to reduce the need for positive pressure or for mechanical ventilation. The head-to-head trials that have looked at Insure versus LISA, and again, I'll use LISA as just a generic term for LISA and MIST combined, have shown that the LISA method is superior. Head-to-head trials of LMA versus Insure have shown LMA to be superior, and LMA versus CPAP alone, LMA is superior. And currently, there's no studies directly comparing the LMA to the LISA procedure. So what about pre-medication? This is also a topic that's near and dear to my heart. Prior to my interest in less invasive surfactant was looking at pre-medication for non-emergent intubations. We know that intubation without pre-medication has been shown to cause bradycardia, hypotension, hypoxia, and increased intracranial pressure, and that all these adverse effects can be mitigated with the use of pre-medication. The American Academy of Pediatrics and the Canadian Pediatric Society have issued statements that state that pre-medication with an anticholinergic, such as atropine or glycopyrrolate, an analgesic, and a muscle relaxant should be used for all non-emergent intubations. So this is in direct conflict with needing the baby to be spontaneously breathing. We know that traditional intubation pre-medication can be used because the baby is going to be on the vent. However, as we've seen, we talked about the rapid extubation with the Ensure technique is not always possible if the baby has respiratory depression or if the baby is paralyzed. And again, the baby does need to not be paralyzed and be spontaneously breathing if you're going to do rapid extubation with Ensure or with the MIST or LISA techniques. The LMA does not require the use of a laryngoscope or direct visualization of the vocal cords. And so we'll talk a little bit more about the adverse effects, but this is less stressful for the baby. So for my study, we did use atropine because with the placement in the posterior pharynx, I was concerned that there'd be stimulation of the vagal nerve, and also 24% sucrose solution for the analgesic. In my trial, I did videotape all the procedures of the LMA placement, and also if in either group, either the CPAP alone or the LMA surfactant group that was then back on CPAP, if either group reached treatment failure criteria, they were intubated and had an ET tube placed. And so all those procedures were videotaped and compared. The heart rate was similar between procedures. This was expected as both groups at placement of the LMA and placement of the ET tube did receive atropine. The thing that was really encouraging for me was that the saturation change, the desaturation, was the same between groups. And again, this was very important to me as the babies in the LMA group only received 24% sucrose solution, whereas the babies in the ET tube group received fentanyl and rocuronium. So in conclusion, the LMA placement was well tolerated and had minimal change from baseline in their heart rate and saturations. What about patient population? So the wonderful thing about the Ensure, MIST, and LISA techniques is that they're all very similar to traditional intubation and can be done on even the smallest of babies, 22 to 23 weeks, because the laryngoscope and feeding tube can fit through there. However, the LMA has constraints for size. So the currently available LMAs on the market do not fit well in babies that are less than about 1,250 grams, which is kind of roughly the 28 weeks gestation. This is a reason that I've heard a lot of people question if they should do this in their institution. My answer to that is that 2/3 of the babies that do receive surfactant are actually greater than 1,250 grams. So this is still something that is currently available and very beneficial to 2/3 of the population that are receiving surfactant. What about FRC? So FRC, there's a nice YouTube video that shows that a lung that's inflated and then has stopped being inflated within about 4 spontaneously breaths, the alveoli start to collapse. And so we know in our tiny babies that are surfactant deficient, this is extremely important to keep those little alveoli that are already open, keep them open. So the utilization of the Y piece, as you can see in this picture here, the LMA itself is here. You can do this procedure completely without any additional equipment, but adding this Y piece, or we'll talk about another potential kind of adapter, allows for the limb here can either be hooked up directly to a PEEP, like a T-piece, with or without a CO2 detector. And so again, that means that the baby can receive EEP continuously throughout the entire procedure. Again, these are important findings because we know that EEP does help in the distribution of surfactant, and we know that keeps those little alveoli open. So what about positive pressure ventilation? This is a hot topic. Positive pressure ventilation has been shown to be beneficial for recruitment of alveoli and increasing FRC. However, there's also a lot of data that's been recently coming out that it's associated with barotrauma, volute trauma, and excitation of the inflammatory cascade. So whether or not positive pressure ventilation or spontaneously breathing results in better surfactant distribution is an area of debate. Animal studies have shown conflicting results. In clinical trials in humans with LISA, which again has no positive pressure ventilation, versus INSURE, which does have positive pressure PPV, have shown that the LISA technique is superior. However, about 50% of the babies in several of the bigger trials have received positive pressure ventilation for rescue for hypoxia. So again, kind of an area of debate, but my personal opinion is that if you have a way to deliver EEP continuously throughout the procedure, do that and only give them PPV if they need some recovery breaths. So it can be kind of a hybrid. Potential adverse effects. Again, the INSURE, MIST, and LISA techniques are very, very similar to traditional placement of the ET tube. So again, the same risks with mouth or pharyngeal trauma, bleeding, and then vocal cord or subglottic injury, since the device is going to be below the vocal cords. In contrast, the LMA sits in the posterior pharynx. This is a picture here, the LMA, the cuff is inflated. Here's the trachea, the esophagus. And so again, nothing is going below the vocal cords. However, LMA does have potential for esophageal injury. You can advance so far that you're into the esophagus rather than the posterior pharynx. And then also something that was really a potential concern for me when I started investigating this method was the risk for laryngospasm. Since the babies are receiving the medication above the vocal cords, there's very much potential for them to stimulate the vocal cords. So this was something that was a major concern for me when I started this. However, we found that this is a theoretic risk and that laryngospasm has not been reported. I've been doing this for about 15 years, and there are several other centers that have done it for about 15 to 20 years and have not had any incidents of laryngospasm. However, again, it is a theoretic risk. So we do encourage that clinicians be prepared for this potential risk with intubation supplies and a muscle relaxant readily available. So what about provider skill and familiarity? This is actually one of the biggest hurdles that I've heard in people when they question whether or not they should start this in their institution. There's something about familiarity, like we are creatures of habit and we like to do what feels most comfortable, even if it's not necessarily the best thing. And so provider skill is said it's very, very similar if you're using any techniques that require the laryngoscope for placement. However, as we know, intubation is fraught with complications. It's got a high rate of adverse effects, and it requires quite a bit of skill on the provider. We know that LMAs are very infrequently used for the most part, and that providers do not feel familiar or comfortable with them. This, however, is starting to change. So kind of going back to skill, we know that intubation is a difficult skill to learn, and that the opportunities to learn or to maintain skills have decreased significantly since we've stopped intubating routinely for meconium aspiration, and because we've had increased use of non-invasive ventilation. In the past, also, LMAs were kind of mentioned as something you should use in case you can't intubate. Most providers had never touched one, never used one, didn't quite necessarily know where they were in their unit. However, since 2016, the guidelines have increased significantly through the newborn resuscitation program. And now that's actually placement as part of the skills for certification. However, even with this, most providers have not actually used one in the clinical situation. However, I'm here to assure you that it is easy to place. In my study, the vast majority of the LMAs were placed in a single attempt and completed within 35 seconds. And something that was really important to me was just to ask the providers, like, how they felt. And the vast majority said, I really, really wanted you there in the first one and just to hold my hand and walk me through it. And after the second one, I felt very empowered, like I could do this myself. So it is a very, very short learning curve. So this is just a pictorial representation of that, is that intubation is a difficult skill. It's like rolling a big, huge, heavy rock up a hill. And LMA still have a rock, but it's much easier to push. So while all these methods are effective, I am here to tell you that the LMA is easy and fast and effective. So let's look a little bit more at how you do this and kind of the history. The LMA has actually been around since the early 80s. It was developed by an anesthesiologist and is currently widely used in the adult population. However, like I was saying, most NICUs kind of had that in we're supposed to use that if we can't intubate them, but I don't really know how to use one. However, they are increasingly being used for not only the difficult airways, but also transport surgeries and other kind of short ventilation needs. As I said, they're primarily the product insert or labeling on them either does not give a lower range or that 2 kilos is the bottom range. However, we found that they do fit into babies that are about 1,250 grams. The thing with this is that there's a case report of it being used, an LMA being used in an 800-gram baby in the delivery room for ventilation and epinephrine administration. And in this case, they used an LMA that had an inflatable cuff that they just did not inflate the cuff. And that's how it was able to fit in this small of a baby. Looking at the literature behind using an LMA for surfactant, there's 2 animal trials and currently 6 randomized controlled trials. The animal trial, this is when I was saying that I got that idea of, wouldn't it be great for these babies in the gray zone if we could just give them some surfactant. I was actually familiar with an LMA from when I was a EMT on the ambulance crew in college, and we did use LMAs in adults. And so I knew that they were available. So I first tried it in the animal model. And so we looked at 24 piglets that were 1 to 2 days old. They all weighed about 2 kilos. We induced lung injury by a saline lavage to induce surfactant deficiency and then put them on CPAP. They were randomized into the control group, LMA or ET tube group, given that their group, and then put right back on CPAP. This shows the results of the time versus the PaO2. So this was their response to surfactant. This is the control group on the bottom. And then the LMA and the ET tube group were very similar in their response with the surfactant. And again, this was very, very encouraging to me because it showed that the the surfactant through an LMA got the surfactant to the lungs equally as well as the gold standard of through an endotracheal tube. And then this was done in a lab where the providers were extremely familiar with intubating piglets and had never placed an LMA and showed that the LMA took about 20 seconds versus 2 minutes to place, so 6 times faster, and required the vast majority were just a single attempt versus 2 attempts with the ET tube. And again, this was very encouraging because these were very skilled intubators for piglets. The other animal trial is looking at 2 different ways or 2 slightly different methods through the LMA. So this one has the catheter for surfactant ending kind of in the proximal portion of the LMA and given positive pressure ventilation versus the tip is actually through the kind of the outlet of the LMA. And this rabbit did not receive positive pressure ventilation. And both ways were equally effective. And probably the biggest difference is whether or not they receive PPV rather than where the catheter itself is. This is kind of a quick little summary list of the randomized controlled trials. Again, LMA versus CPAP alone or LMA versus Ensure. Most are kind of in the 28 to 36 weeks, greater than 2 kilos, going for those gray zone kids. So these are not the babies that you think are gonna do well on just CPAP, standard CPAP, maybe in that 21%. having a little bit of mild retractions. This is again is trying to capture those babies that are in the gray zone where they're not quite bad enough to intubate and get surfactant, but you certainly could, but you also feel like they're struggling. So they varied in what they were given for pre-medication and kind of the primary outcomes, but in summary, all the primary outcomes were in favor of the LMA. So a quick little closer look at the trial that I ran. We enrolled 103 babies. Again, I really wanted the kids that were in that gray zone, so the 30 to 40% oxygen. Again, the control group received just standard CPAP. The LMA group just got CPAP with LMA surfactant and put right back on CPAP. And we had the same intubation criteria. The kids were about 2 kilos, about 33 weeks gestation, about the 35% oxygen, and their CO2s were right where I was hoping they would be, kind of in the 50s, where again, not quite bad enough to intubate, but could, and struggling a little bit. Intubation criteria was FiO2 greater than 40, greater than 65 on their CO2, or 722 on their pH, or severe apnea, hemodynamic instability requiring pressors are deemed necessary by the provider. And showed that the LMA group had about a 38% intubation rate versus 64% on the controls. And this was statistically significant. This was something that was surprising, though. I really did think that the groups would differ by their duration of CPAP or their oxygen requirement. I really thought that this was going to get them over their RDS more quickly, but it didn't. But what it did show is that the RDS kind of runs its course over the first 3 to 4 days. But with LMA surfactant, you can support them on less support, so less of CPAP or less oxygen. No difference in the incidence of air leaks, chronic lung disease, severe high VH, or PBL. So in conclusion, the LMA can be used to administer surfactant. It's easy and effective, resulted in 26% fewer intubations, and the procedure was well tolerated. So how do you do it? So this is kind of a quick, little picture of the equipment that can be used. The nice thing is that it's an incredibly versatile procedure. So it's being used around the world in both places that are well equipped with resources and those that are low resource. So whatever you have at your facility, we can make it work. You do need an LMA or a supraglotic airway device. And then all you need is your surfactant in addition, if that's all you have. If you have addition or equipment that's available, a CO2 detector is very, very helpful. A Y piece, again, is very helpful in that you're able to maintain your EEP continuously. And then we'll talk about the different ways to get the surfactant into your catheter, your Y piece, or your LMA itself. This was how we used to do it. We used to cut a feeding tube. This is an 8 French feeding tube that I just cut to the proper length. You wanted it about kind of the distal end of the LMA if you have a choice. It doesn't really matter. You can administer it from the top, but every once in a while there's an air bubble and then it kind of bubbles over. So if you're able to fill from the bottom, that's a little bit helpful. And so this with the Y piece, I measured and it's about 14 centimeters. So we have a measuring tape, the scissors in the kit also. And then we need a Y adapter, a Christmas tree adapter, because these are feeding tubes and they don't have a lure lock for the surfactant syringe. But again, whatever is at your facility can make it work. It looks very similar to an endotracheal tube, except for at the end, instead of going through the vocal cords, there's a mask that sits in the posterior pharynx. LMAs come, most of the currently available ones on the market have an inflatable cuff. So you have the syringe that inflates the air. The only one that's on the market that's not an inflatable cuff is called the eye gel. And this is kind of a nice little malleable gel mask. These are the different ones, just a sampling of what's on the market. You can see that they all have kind of a different amount of curvature. And then again, this is the eye gel. It's the only one that doesn't have an inflatable mask. And then these are a picture of what the apertures itself look like for the mask. Some have fenestration, some don't. And so do I think it matters? No, I think whatever is available at your facility. Adapters, again, the Y piece is what we currently use. We also have a T piece available at our institution. The thing that I like about that is that the surfactant syringe can hook up directly to the side, and so it eliminates the need for the feeding tube, the scissors, the measuring tape. So again, whatever you have, and again, it's just nice if you have one so then you can have continuous EEP. This is a picture of what it looks like with the T piece. The surfactant syringe is hooked up directly to the adapter. The PD cap here with the positive pressure, the EEP being administered here. And again, this is just a picture with the eye gel that does not have an inflatable cuff. The surfactant administration, like I said, here you can cut the feeding tube. We also have something available to us that looks very, very much like a closed suction catheter. And so you can put that on this limb of the Y adapter, feed it down. If you go to the red mark on the access catheter, that's about the distal end of the LMA. And so that's also a method that's available. CO2 detectors, I've already mentioned the PD cap or just the color imagery where it changes from purple to yellow if CO2 is detected. We also have available in our unit capnography. So this is the portable one called the EMA. We also have them on our monitors, and this actually gives you a digital readout of the number for the CO2 and also the waveform. So that has been really, really wonderful in terms of kind of finding that sweet spot where you're just over the trachea, not too deep and kind of into the esophagus and not too high and kind of up in the posterior pharynx. So if you do have capnography available, again, it's really a wonderful addition to just find that beautiful sweet spot. So this is what we have at our facility. We have a little kit that's a little like kind of clear plastic tub that has all the equipment and also has this algorithm. This is an algorithm that I made that I'm happy to share. It just kind of goes through kind of setting the stage with the equipment that you need at the bedside. The first kind of bluish aqua is preparing the baby with sucrose, atropine, having them supine. One of the most important factors here is having them positioned with that sniffing position so that their airway is really readily available. So just like intubation, positioning is extremely important to success. We aspirate the stomach contents initially. That's so that at the very end of the procedure, we can also aspirate and see if any surfactant has leaked. You can leave the NG or OG in place or it can be taken out. I've tried it both ways as I want this to be like kind of minimally irritating for the baby. And so leaving the CPAP and the NG or OG in place is an option. You just need to make sure that when you're done, if you've left it in place, that you confirm that the OG or the NG is still in the stomach, as it can be pulled out a little bit with the procedure as you're having the LMA pulled out of the mouth. The procedure itself, you just slide that LMA in until it can't go further until you hit some resistance. And then again, if you have the ability of CO2 detection, that's great. You listen for bilateral breath sounds and look for response on the oxygen saturations. You can give the surfactant itself in anywhere, any size aliquot you want. I find that 2 mLs is kind of a nice happy medium and not giving them so much that their sats really tank when they're at the surfactant alveoli. And it gives them a little bit of break between aliquots. And then when you're done, if you have a cuff, you just need to deflate the cuff before you pull it out. And if there's not a cuff, you just pull it right back out. And then again, at the end, we aspirate the stomach to see if there's any surfactant that's leaked. If there is some, it's not a very big deal. The vast majority in my study, 50% of the babies had either 0 or less than 10% of the dose in their stomach. There's been an abstract that I saw that actually shows that surfactant may be protective against NEC. So I don't know that it's necessarily something that we'll be investigating further, but it's certainly not harmful to the baby. And that our doses for surfactant dosing are at the point where they're several fold more than what the baby actually needs in their lungs. And so having a little bit leak is usually just fine and it's very effective still. So this flowchart can be downloaded at the site there. We also have a QR code. This video that we've already kind of walked through is also available for free on YouTube. There's a training video that I've made that's 14 minutes long, and it really goes through step by step in terms of the equipment and also the step by step on the procedure, and really walks you through it. This is also available on YouTube for free. There are some training modules. There's a Bubble CPAP Institute that's free on the website given here. And the modules 6 and 7 are kind of what I've gone through today. There's a NEO review article that again just kind of walks through what we went through today. It also has links to these videos and the algorithm itself. There's a YouTube channel that one of my colleagues and friends has put together that this is also available on YouTube. And then we also have a Facebook site that this has been really, really fun. It's extremely international. And so encourage you to join. Again, this is an international Facebook site that's just directed specifically for SALSA. And again, like I said, this is being used in high income countries, as well as there's a lot of work that's being done currently in low and middle income countries that have access to CPAP and surfactant, but not necessarily mechanical ventilation. So with that, I will close and open it up for any questions.
Thank you, Dr. Roberts, for that talk, taking us through the journey of SALSA. So one of our participants asked, do we need to give additional doses for the reflux or the amount of surfactant which goes into the stomach?
Great question. So we go by just purely how the baby responds. And so we get kind of a sense based on the dose that's in the stomach. Like I said, the vast majority of the times that we do this, there's very, very little or none in the stomach. And the baby really does respond quickly. The vast majority have weaned dramatically on their oxygen requirement, if not to 21%, at least dramatically down within just 2 to 3 or 4 minutes. And so based on the clinical response and the amount that you got out of the stomach, it's certainly fine to redose. The other question often comes up is, can you give a second or third dose at the appropriate time? And the question is absolutely.
So one of the participants has asked that what makes SALSA a better method compared to thin catheter method? Although the evidence that the thin catheter method decrease BPD and other morbidities like IVH and PVL.
Right. So again, the piece that I like about the LMA is that it's just really, really easy and fast to place and takes very little skill. And so essentially you just feed it down until you get resistance. And so the issue or the kind of the difficulty with LISA or MIS is that you still have to feed the catheter through the vocal cords. And so to me, the physiologic effects on the baby are extremely similar to intubation. And so for that reason, it's actually, you just kind of have to choose what you think is the lesser of the evils. So I have a difficult time intubating a baby that doesn't have pre-medication on board. And so to feed a ET tube or a thin catheter through the vocal cord seems very minimally different. The thing that's wonderful about Mr. Lisa is that the baby, it can be used, down to 22, 23 weeks. And the baby remains spontaneously breathing. And the major difference between those two is that this is a diameter that's in the airway. So if you think about how much of the diameter of the airway that the ET tube takes up, the baby to remain spontaneously breathing would have to breathe through essentially a straw, versus with the feeding tube, it takes up a smaller portion. And so they're able to spontaneously breathe without that increased resistance. So it's a long-winded way of saying, none of the procedures or options are without a cost also. So you just have to go with what you think is best in that clinical situation.
So one of our other colleagues has asked, what about the babies who are VLBW babies or less than 1.5 kg babies, in whom we see the incidence of RDS is maximum and they often require 1 or 2 doses, but LMA is not available for those babies, although there are anecdotal reports of using them in 1 or 2 babies.
Right. So it goes back to the currently available ones do only fit in greater than 1,250 grams. So I would encourage you to, that's still 2/3 of the population that gets surfactant. And I also think it's really important, like these babies can be given a less invasive method. So, it's still 2/3 of them that could benefit. So I encourage you to at least consider LMA in these kids. There is a smaller LMA in development and will be on the market in the future.
Other interesting question is, what about nebulization? I think in the participant, that is the only non-invasive method available. So can we see that is the future method of giving surfactant to all babies with RDS?
Yes. Yes, that is something that is so incredibly encouraging and needed. This is something, like I said, has been sought after by many companies for 3 decades now. And we're getting closer and closer with new technology. So the ONI study that just finished did show that there was a 50% decrease in need for intubation. It worked best. It worked really well in the babies that were greater than 1 kilo. So again, until when it's clinically available, once the FDA approves it, then that would be a great option. That is by far and away the best option, least invasive, if you have that available on the equipment, to give that. So again, I think that there's not going to be one method that fits every baby in every institution. And so I think this is going to come down to really being a hybrid, where if you have aerosolization available, fantastic. And the baby is greater than 1 kilo. That's the preferred method for least invasiveness. And then if we have a baby, if you don't have aerosol, but you have LMA, then do that in the kids that are greater than 1250. And once we have a smaller one available, that will open that population even further. And then again, if we don't have those, or it's a really, really small baby, then LIST or LISA would be a good choice. So again, this is going to be kind of one of those where it's going to be a hybrid, and make a decision based on the size of your baby, how severe they are, what you have available, and what you think would be best in that clinical situation.
Thank you for that wonderful explanation. And definitely one size doesn't fit all, and we have to cater depending on the method which fits us, which we are trained in or which we are practiced, and keep doing that and try to be as non-invasive as possible. If any participant wants to ask question directly before we call it a day or night, you're free to unmute yourself and ask directly.
Yes, please do. And then my email is given on that on that slide here. So please email me if you're interested at all in learning more about this. I have an email that's prepared that I send out that has the trials included, as well as the algorithm, the links to the YouTubes, Facebook, those types of things, all kind of packaged in one. And I'm more than happy to meet and try and do some training by Zoom or in person if that works. So I'm available to help if you're interested in.
Which is better, iGel or ProSeal for surfactant administration?
You know what? I think it again goes back to personal preference. So we use the LMA Unique, which is an inflatable cuff for my trial. Those were really well received. Then we started using the iGel, and providers were like, well, this is great. It decreases. The only thing that's really different is that the step of inflating and deflating the cuff. But for some reason, even though it takes 3 seconds at most to do those two things, it just felt like one less step, and it felt nice. We did find that the iGel works best if you warm it up. And so now we put a heel warmer on the mask before we start. So that's now an additional step. And then I would say that about 50% of the providers now like the LMA Unique, and about 50% like the iGel.
So again, that depends on person to person and unit to unit. With that, we come to end of today's session, and we are very thankful to Dr. Roberts for taking her time from her busy schedule and giving us so thoughtful, innovative method of giving surfactant. Although we use thin catheter method in our unit, but still we haven't started using LMA in our new unit. and we hope to introduce it soon. With
Great.
the
I'd be happy to come.
fourth wave doesn't come, we definitely will like to have you in person, at least in our unit.
That'd be wonderful.
With that, we come to this end of the session, and we thank you again for your time, energy, and making it so easy to understand and so illustrative with all your diagrams, pictures, charts, and YouTube videos. Thank you so much. It was lovely having you.
Thank you. My pleasure.
And
Bye-bye.
thank you to all the participants for attending the session.